Today we're going to talk a little bit about a patient who shows up with fever, chills, and a cough. So you suspect this patient has pneumonia and you work them up. I'm going to talk in a couple of minutes about what exactly that workup entails because it depends on where you are and what tools you have access to. But let's say this workup is suggestive of pneumonia. What do you do then? You have to decide, do I put this patient in the ICU, in the hospital, or do I treat them outpatient? And how do I make that decision in my plan? So you can use the PSI, Pneumonia Severity Index, or the CURB-65 score. Both of these scoring systems are used to evaluate the risk to the patient. How sick are they? Where do they need to be treated? Let's start with the CURB-65 score because it's a little bit more versatile. So C stands for confusion. Is there a change in mental status, person, place, or time, or a mini mental status exam less than 9? The second aspect is urea, so a BUN greater than 19. R stands for the respiratory rate, and here we're talking about a person who's short of breath, so they're going to have a respiratory rate over 30. The blood pressure, this person might be hypotensive, so we're talking systolic blood pressure less than 90 or diastolic less than 60. It's important to note that either one of these qualifies, so they're independent criteria. Finally, 65 refers to a patient who is 65 years old or older. Each of these elements individually become 1 point in the CURB-65 system. You can then add these points up to try and evaluate the total risks that the patient faces, and based on that risk, make your clinical decision. So a low-risk patient in this system gets 0 to 1 points. And to give you an idea, 1 point is about a 2.7% chance of dying in 30 days, according to previous studies. So you can treat this patient in the outpatient setting. A moderate risk is comprised of those patients who have 2 points. In studies, these patients have faced up to 7% risk of 30-day mortality. These patients, the exact treatment is a little bit more of a gray scale. These patients can be treated with a short inpatient hospitalization or a more closely supervised outpatient form of care. So it's really based on your experience with the patient and how healthy you think they are baseline. And this is one weakness of the CURB-65 system, is there is a little bit more question with this. Finally, the high-risk patients are those who are 3 points and above. 3 points and above, specifically 4 or 5 points in studies have equated with about 30% 30-day mortality. So these patients, you're really deciding whether or not to urgently admit them to the inpatient service or to the ICU, because 30% is just a huge risk of 30-day mortality, and you really want to watch these patients very closely. So where did the CURB-65 system come from, and how are we making these huge decisions based on it? So the original paper is this one, Defining Community-Acquired Pneumonia Severity on Presentation to the Hospital. And this was by Lim et al., and it was published in 2003. This is important because, as I'll talk about in a couple minutes, some of the laboratory studies are based on the time period. So basically, they looked at a bunch of risk factors and how they correlated with 30-day mortality. Specifically, they chose age over 65, temperature, mental confusion, urea, albumin, and low blood pressure. These things specifically had very low p-values, so they correlated very highly with 30-day mortality. Now, if you're listening, you heard me mention albumin. This isn't in the CURB-65, and this relates to the time period. If you read in the discussion, they say that though albumin did correlate with 30-day mortality very highly, their hospitals were unable to get this very regularly, especially outside of business hours. And so they didn't include it in the CURB-65. It might be a useful thing for you to consider with your patients who are on the cusp and you're trying to make a decision about, because that was 2003. So what exactly is the PSI and why is it important? So the PSI is another similar system. Some studies have shown that it is able to better define low-risk patients. So And if you have access to more resources, it can be quite useful. So it looks at demography, comorbidities, which the CURB 65 does not. It is ultimately used for the same thing. How do you identify the low-risk patient who can go home versus the high-risk patient who needs to be in the hospital? What really sets this apart is there's a number of laboratory studies that go into this score. So you're evaluating pleural effusion, you're using ABG values, and metabolic panel values. If you have access to all of this, if you're in an emergency room, the PSI might be the better test in making a decision. But what about the flip side? You're at a small outpatient clinic and you have access to no blood or chemistry studies. You can't do a urea. What do? This is the beauty of the CURB 65 original paper, because they also suggested a CRB 65. The CRB 65 does not use the urea, so you don't need any studies. Oh goodness, my hand-eye coordination is terrible. So with the CRB 65, you don't need any serum studies to make your determination. You just use confusion, respiratory rate, blood pressure, and age, and you can then try and risk stratify the patient. In this case, if you lose the urea variable, 0 points is really the only case that is considered low that you can truly treat as an outpatient. 1 to 2 points becomes moderate and you need to evaluate for hospitalization. High is still just anything above 3. And again, we're talking at 3 or 4 points, the risk of mortality at 30 days was about 31%. So what do you do with the workup? I say this for last because, again, it depends on where you are, what you have access to. So the first study, the gold standard, is the chest x-ray. Why do you want the chest x-ray? Well, number one, it gives you insight into what kind of pneumonia we're talking about. Is it a lobar pneumonia? Is it a different type? And this is useful in risk stratification and trying to understand the underlying etiology. The second is it's the gold standard in the diagnosis. So if you're still considering acute bronchitis, you can rule that out or narrow your differential using the chest x-ray. Again, remember, it's a PA and lateral that you want. So the second study that you might consider is a sputum culture with a gram stain. So this is useful in identifying the organism, the etiology, to see if your antibiotic is going to be useful, and also for ruling out atypical causes. You might also consider a blood culture. Blood culture is useful if your patient has fever and chills. The organism is likely in the blood, and you can identify it that way. You might consider a metabolic panel, again, if you're using these rating systems that we've discussed. You might need a BUN and other sodium, which are available on metabolic panel. And ABG is painful and expensive, but it is used in the PSI, and that's why I put a question mark next to it. You might also consider an H&H, as that is, and a CBC.